Ladies and gentlemen, dear colleagues, I am more than happy to be involved in this course and to have the opportunity to speak about the management of bowel endometriosis. So here are my disclosure, and the objective of my presentation is to describe the surgical procedures employed to deep endometriosis of the rectosigmoid, to discuss main postoperative complications related to each procedure, and also the delayed functional outcomes and recurrences rate related to each procedure. So as you know, when we speak about the rectosigmoid lesions, we have to keep in mind that there are two major types of lesions. The first one, they are low rectosigmoid lesions, such as posterior adenomyoma, because they are nodules which are attached on the posterior rectal, on the posterior uterine wall and isthmus, and also involve the vagina, the parametria, and the mid or low rectum. So these nodules are very well seen by ultrasound or MRI. The second type is represented by solitary nodules on the sigmoid colon, and they may be overlooked because usually the sigmoid involved is mobile. However, from while to while, they may be connected to left ovarian endometriomas. There is a risk of occlusion because these hidden lesions may be overlooked until the moment of the subocclusion or the occlusion. Now, the question is how the surgeons usually manage this kind of rectosigmoid nodules. And as you see, there are two types of approaches. The conservative approach, based on the shaving and the disc excision. And the second one is the radical surgery based on segmental colorectal resection. So here you have the results of a survey carried out in France 5 years ago. You have to know that in France, more than 1,100 women have surgery for colorectal endometriosis every year. And as you can see, in 90% of cases, this surgery is carried out laparoscopically or with robotic assistance. In more than half of cases, French surgeons perform a conservative procedure, meaning either shaving or disc excision. And this is my personal experience in 1,060 patients managed for colorectal endometriosis from 2005 to March 2020. And as you can see, the employ of different techniques is balanced, meaning that I use the shaving, disc excision, and colorectal resection in similar proportion, depending on the features of the nodule and of my patients. But in 60% of cases, I can conserve the shape of the rectum by performing a conservative procedure. Now let's see how the rectosigmoid endometriosis can be managed, and let's have a look at each technique. So the shaving is represented by the excision of rectosigmoid nodules without opening the rectum. It can be done using scissors, laser, plasma, harmonic scalpel, laparoscopically, robotically. The goal is the complete excision of the nodule without opening the bowel and without removing a piece of the bowel. You have, however, to check the lack of bowel perforation during the shaving. And if you think that the bowel wall is too thin, you may reinforce it using stitches and or to convert to disc excision. There are many papers about the shaving and the benefits of the shaving. reported by several authors, well-known experts such as Jacques Donez, Nejat brothers, Harry Reich, Renato Serracchioli, etc. Now, you have to know that when you perform a shaving, the excision, the complete excision, is difficult to do, particularly in big nodules. So maybe it is incomplete from a microscopic point of view. However, the shaving presents some advantages. The first one is the low rate of complications. The second, the low rate of worse impaired functional outcomes, meaning that the bowel movements are never impaired by the shaving. It is very likely that the rate of recurrences is higher after shaving than after other procedures. And in my experience, it is at least 8% at 5 years. However, it is a very good technique in elderly women or in women accepting to have a post-operative amenorrhea in order to prevent the recurrences. And in my opinion, this is the first line, and it should be done each time it is feasible. The second technique is the disc excision, meaning that once the shaving was done, the shaved area is removed using either scissors or a transanal stapler. The goal is a more complete excision than after the shaving, and the conservation of the shape of the rectum, because only a patch is removed. The advantage is that the mesorectum is not sectioned, so there is a lower risk of bowel denervation, and there are not major variations in the length and the volume of the bowel. There are numerous authors who published on this technique, such as Nejat brothers, Gordon, Landy, and Australian teams of Eng. However, it has been shown that the resection of microscopic foci may be incomplete in 25 to 40% of patients, meaning that microscopic foci may surround the nodule which was removed by disc excision. However, the major advantages are the preservation of the mesorectum on the rectal shape and the absence of the stenosis. There is never stenosis after the disc excision. However, if you reduce the length of the anterior rectal wall by disc excision, you may have a posterior pouch, which probably does not impact the bowel movement. So I have a large experience with the disc excision because it's the technique I prefer. So to date, I carried out it in more than 300 patients by using either circular staplers or a semicircular stapler, the so-called Rouen technique. I observed that the recurrences rate is very low, about 1.3%, and I have never recorded a stenosis of the bowel after the disc excision. So the third technique is the colorectal segmental resection. This is the radical management because you will remove a piece of the rectum and the colon, which is involved by one or several nodules. This is the most used procedure in colorectal surgery. So the colorectal surgeon are always likely to propose it if you call them to help you in the surgery of deep endometriosis. However, I think it should be reserved in huge subocclusive nodules or nodules responsible for a too long bowel infiltration, too long to be removed by disc excision, in lesions which are circumferential or multifocal lesions that are not very far each other. In this case, also, you may, even though you cut a piece of the colon and the rectum, you may have microscopic foci outside the limit of the resection in up to 30% of cases. However, the recurrences rate is very low. It's about 1 to 2% at 5 to 10 years. However, you have to keep in mind that you may have a stenosis of the anastomosis after corrector resection in maybe 10% of cases. When you have multiple nodules, the colorectal resection may be a good solution, but also if you have a distance over 7 centimeters between a rectal nodule and a sigmoid nodule, you can carry out two separate procedures, a disc excision on the rectum and the short sigmoid colon resection, instead of a long and low colorectal resection, which may be responsible for functional troubles. Now, what are the immediate complications related to this technique, and is there a difference between them? So this is a series published 2 years ago in 364 patients managed by various techniques in my department. And you can see that the rate of complications, Clavien-Dindo 3B complications requiring a second procedure to solve the complications, increases from the shaving to the segmental colorectal resection, while the stenosis of colorectal anastomosis is only recorded in patients with segmental colorectal resection. As regards the bowel fistula, we have just published a paper in Human Reproduction about the bowel fistula, which is the major complications of the surgery. So we checked it in 1,100 patients, and we observed that the surgery for colorectal endometriosis results in about 3% of fistula, 2/3 of them are rectovaginal fistula, and 1/3 of them are bowel leakage. And when we look at the risk factors of this fistula, we observe that the procedure on the rectum is the major risk factor, meaning that when you perform disc excision or segmental resection instead of shaving, you increase the risk of fistula about 5 times, meaning that the bowel suture is the major risk factor for postoperative fistula. We also saw some difference between the rectovaginal fistula and the leakage. It is shown that the rectovaginal fistula, meaning that the gas and the stools get out from the vagina, they are not terrific clinical symptoms because you never have peritonitis because everything goes out through the vagina. However, it is very difficult to repair because the stoma was present during 10 months, and the patients had up to 4 additional procedures to repair the rectovaginal fistula. While the bowel leakage, which always results in a peritonitis because the stools get out into the abdomen, it is easier to repair because after 5 months, a majority of patients have a natural healing of the fistula only by stoma. And also the period to required for the healing is shorter in bowel fistula than in bowel leakage than in rectovaginal fistula. Now, could stoma prevent the fistula? Is a very good question. However, in our opinion, it does not prevent the fistula. It prevents maybe the complications related to fistula, but the unique factor we identified related to the risk of fistula is the height of the colorectal anastomosis, meaning that when the rectal suture is below 8 centimeters from the anal verge, the risk of fistula increases 3 times, with or without stoma. But I think more important, even more important than bowel fistula, are the functional outcomes, because the functional outcomes may persist during years and years after the surgery, and not only some months as the bowel fistula. So the functional outcomes represents a very complex concern and multifactorial concern. Multifactorial because the rectal function depends on the rectal shape, which depends on the type of surgical procedure carried down the rectum. So if you carry out a disc excision and the shaving, you keep better the rectal shape than you perform when you perform a correct resection. But also it depends on rectal innervation and the possibility to perform a nerve sparing during the surgery. But also it depends on hidden preoperative functional troubles such as irritable bowel syndrome or chronic constipation. Now, every surgeon involved in the management of rectosigmoid endometriosis should be aware about the risk of low anterior rectal resection syndrome. And this is terrific, a terrific outcome. And it may be related to the occurrence of the rectal denervation during the surgery or due to the endometriosis itself, resulting in constipation, hypotonic rectum, major exoneration troubles. It may be related to rectosigmoid stenosis, resulting in constipation and dyschezia. It may be related to the reduction of rectal reservoir and rectal shape, resulting in frequent bowel movements and urgency. And it may be related to the risk of fecal incontinence and urgency, but also associated to preoperative voiding troubles, such as a hypertonia of the anal sphincter and the dysynergia. And avoiding these major complications may be very challenging, even though the surgeon is very experienced, because you came to realize that it is a multifactorial concern. After our surgery, the LARS may be due to the rectal denervation, for example, when we section the splanchnic nerves in large nodules of parametria, or when we release the rectosigmoid when we cut the mesocolon. It may be due to rectosigmoid stenosis following 10% of our colorectal anastomosis. I emphasize that stenosis never occurs after the disc excision. It may also be due to the reduction of rectal reservoir when we carry out the long or low colorectal resection. It happens much less after disc excision. And it may be due to the risk for fecal incontinence or urgency when we perform a low colorectal resection, resulting in a situation when the high intracolic pressures directly impacts on anal sphincter in the long run. And my colleagues from Aarhus in Denmark checked the LARS score before and after the surgery, and they were very surprised to observe that patients with major LARS after the surgery, or the rate of patients with major LARS after the surgery is comparable with the rate of preoperative LARS, meaning that the rectal function may be impaired before the surgery and simply removing the rectosigmoid nodules may not be enough to restore it. So for a long time, I was sure that conservating the rectal shape will be enough to preserve the rectal function. And for this, to demonstrate this, I carried out the first randomized trial comparing the conservative approach to colorectal resection. And I was very surprised to see that overall rectal function was not different between patients managed by colorectal resection and patients managed by shaving or disc excision for all rectal endometriosis confounded. However, I reported a significant risk of bowel stenosis after colorectal resection. However, this trial showed 5 years after the procedure that the improvement of the quality of life of the rectal function is constant 5 years after the procedure. The patients have less pain, have better gastrointestinal score, and the overall better quality of life. Far from more, we show that 5 years after the procedure, 80% of patients who intended to get pregnant were pregnant, and 75% of patients which were infertile before the surgery were pregnant, and the majority of pregnancies were natural, meaning that the surgery of a colorectal endometriosis is efficient in infertility. Now, I think that the conclusions of my randomized trial should be moderated when the nodules infiltrate the low rectum, lower than 8 centimeters above the anal verge. So in these cases, I still believe that performing a disc excision instead of colorectal resection may preserve the rectal function, and I demonstrated it in a paper which is in review in Diseases and Colorectal. Now, how about the recurrences risk? I told you that we observed that the rate of recurrences is probably higher after shaving than after over 2 procedures. And we tried to estimate the risk of leaving behind microscopic foci after each procedure. And I think we leave microscopic foci after shaving in almost 90% of cases. We leave them also in up to 40% of cases after the disc excision, but we still leave them in up to 30% of cases after the colorectal resection, meaning that the microscopic complete removal of endometriosis foci is probably not a realistic goal in this surgery, and it would be better to focus our attention on the preservation of the rectal function. That's why, in my opinion, the free techniques are useful depending on patient's features. So in conclusion, I think that the surgery of endometriosis, particularly of the rectal endometriosis, is a new specialty, which is challenging and complex, maybe as challenging as that of the gynecological cancer. The minimally invasive approach may be feasible in more than 90% of cases, because during the last 2 years, in more than 300 procedures, I opened the abdomen in only 1 case, so it is feasible. We have to focus on the quality of life because our patients will live maybe 60 years after our surgery, so the quality of life should be better after the surgery than prior to the surgery. The conservative rectal surgery is feasible. It must be the first line. The immediate complications risk is lower when you perform the shaving. The functional outcomes are multifactorial and may be improved after conservative approach in low rectum. There is no demonstrated benefit related to routine use of radical surgery. So in my opinion, there is no reason to carry out a colorectal resection in all patients. And I think that the balanced use of free techniques should be individualized, and it should represent a kind of custom-made management. So thank you very much. And if you want to see more about these procedures, you can see several hundred of procedures on my LinkedIn account and the YouTube channel with comments in English. Thank you very much, and you're very welcome in Bordeaux.